So the next topic after such a vibrant talk by ma'am is adolescent endometriosis. Is it different? So the idea of taking this topic is, we all get girls in our OPDs with symptoms which look like endometriosis, but then we wonder for our adolescent girls what all we can do as far as examinations and hormonal treatment is concerned or not. So I tried to put in some guidelines here for the benefit of everybody, and it's kind of more of a revision which we are doing in our day-to-day practices. So I'll take you through. So the basics which I have made for this talk is ASHRAE guideline 2022, which I have kind of jotted down in form of points, so that we have a revision regarding how we should be tackling young girls who are come to us with suspected endometriosis. So let's look at the statistics first. Incidence of adolescent endometriosis, when we look at literature, the range varies a lot. It is from 25% to 73%. And pathophysiology is like in adult endometriosis. It is also, kind of unknown. Endometriosis not only is seen in premenarchal girls, but also in pre-thylarchal girls, suggesting multifactorial peripubertal etiologies of the disease in adolescent population as well. Now, diagnostic process as far as these guidelines are concerned. So these guidelines say that diagnostic process in adolescents, it is rather more complex, and awareness of endometriosis in adolescents in health workers is low as compared to adults. So these guidelines, when they are compiled, they the basics for these guidelines are they go into the literature and then they look at large studies, meta-analysis. So they say that health workers, the knowledge about adolescent endometriosis is generally not to that extent as compared to an adult endometriosis. And adolescents on an average waited 3 times as long as adults for getting into the treatment. It took longer before a diagnosis was made. If we compare it with adults, so they took 5.4 years on an average to diagnose adolescent endometriosis, whereas for adults, it was diagnosed in around approximately 2 years. And most of the time, adolescent endometriosis was not taken seriously by gynecologists. And most of the time, the girls were being told that there is nothing wrong and, it is only a pain which can subside by taking analgesics and all those things. So one thing which is very specific I found in these guidelines and literature is, if dysmenorrhea is associated with nausea in adolescent girls, then it may point towards endometriosis. So most of the times, if it is not endometriosis, they can come simply with pain. But if they specifically complain of nausea, then think of endometriosis. So in adolescents, clinicians should take a careful history to identify possible risk factor for endometriosis, such as positive family history, any history suggestive of obstructive genital malformation, early menarche, and short menstrual cycle. And clinician may consider endometriosis in young women with cyclical absenteeism from school, or those girls who use oral contraceptive treatment for dysmenorrhea prescribed by some gynecologist. So in adolescents, clinicians should take a careful history and consider the following symptoms: chronic or acyclical pain, particularly combined with nausea, dysmenorrhea, dysuria, and dyspareunia, as in adults also, and cyclical pelvic pain. And factors which correlate with deep endometriosis in adolescents, the factors which can be pointers is positive family history of endometriosis, again, non-contraceptive use of oral contraceptives, and absenteeism from school. These are also indicators for deep endometriosis in adolescents. Now, coming to clinical examination. So there is something which I would like to share, that these guidelines also say something about the vaginal exam, because we are really scared of, whether vaginal examination can ever be done in adolescent girls or not. So clinical examination, including vaginal examination, whenever appropriate. So this word, carries a lot of meaning here, or I will say hidden meaning. Whenever appropriate, should be considered to identify deep nodules or endometriomas in patient with suspected endometriosis, although the diagnostic accuracy is low. So I'll come to, the protocol for if at all you want to do a PV examination, what should be done. So in women with suspected endometriosis, further diagnostic steps, including imaging, should be considered even if the clinical examination is normal. So you examined the patient clinically, whether you did a PV or PR. maybe the girl is sexually active and you could counsel the girl for PV, or you did a PR, but still symptoms are pointing towards endometriosis, but there is no finding. Even then, imaging should be done in such girls. The GDG recommends, Guideline Development Group recommends, that before performing vaginal examination or rectal examination in adolescents, the acceptability should be discussed with the adolescent and her caregiver, taking into consideration patient's age and cultural background. So we have to, sit across the table, explain the patient. If she's comfortable doing PV, explain it to her attendant or the parent who has accompanied her, and then only we should be doing transvaginal, the pervaginal examination, if at all. Now, coming to the imaging, in adults, transvaginal ultrasound is most appropriate, but in adolescents, especially in those with intact hymen, TVS should only be carried out after careful consideration with patient and her caregiver. Alternatives for TVS in adolescents, all of us know, they are transrectal, transperineal, and full bladder transabdominal, though the accuracy of transabdominal is definitely less, but transrectal scan is a very good modality for young adolescent girls. So transvaginal ultrasound, as per guideline, is recommended to be used in adolescent in whom it is appropriate, as it is effective in diagnosing ovarian endometriosis. If TVS is not appropriate, then MRI, transperineal, transrectal, and transabdominal scan can be done. Lab parameters like in adults. So, we are just discussing, is it different than adult endometriosis? Are there any real differences, or it is the same? So as far as even adolescent endometriosis is concerned, it is CA-125, not recommended for diagnosing or ruling out endometriosis at all. So when to decide for laparoscopy for diagnosing adolescent endometriosis? In adolescents with suspected endometriosis, where imaging is negative and medical treatment, whether it is hormonal treatment or NSAIDs, they have not been successful, diagnostic laparoscopy may be considered. So if you recall the guidelines, especially for infertility in adults, so they say that laparoscopy only for diagnosing endometriosis is never indicated. Patients who are coming to me for fertility, their ovarian reserve is less, they have pain. So just to diagnose that she is endometriosis, I won't do. But in adolescents, there is a long journey, probably, to adulthood and all those things. So girls where I'm strongly suspecting endometriosis, we are suspecting endometriosis, and she's not responding to the conventional treatment, there we can consider a diagnostic laparoscopy. And whenever a laparoscopy is performed, clinicians should consider taking biopsies to confirm the diagnosis histologically. Although if the histology is negative, then it entirely does not rule out the disease. So again, coming to diagnostic laparoscopy in cases of adolescent endometriosis, endometriosis between adults and adolescents on laparoscopy may look different. So I'll just project some pictures in the next slide. There may be atypical red or clear lesions as compared to adults. And rarity of deep or adenomatic type of endometriosis is there usually, which is found in adults. Usually it is not there in adolescents. So there can be white foci. Can you see these pictures? They are absolutely white foci. There can be transparent lesions. So they are also, so in adolescents, the picture may be a little different. Sometimes it may be absolutely black, some lesions they are there, or typical, like what we see red lesions as in adults. So they may have a different look on laparoscopy when we take up these girls for laparoscopy for, diagnosing endometriosis. Now, coming to histology in adolescent girls, incidence of endometriosis, which is diagnosed on laparoscopy with chronic pelvic pain not responding to treatment, was 75%. That's why they say that whenever you do laparoscopy only for this indication, try to take biopsies and send them for histopathology, and you will find 75% of the times when you were suspecting it and the girl was not responding to the conventional treatment, you will find histologically it is endometriosis. Then coming to medical treatment, is it different in girls? So high quality evidence about efficacy of medical treatment of endometriosis in adolescents is scarce. There are not many papers, there is not much literature on this. So, but whatever the literature is available, efficacy of NSAIDs or other analgesics in adolescents with endometriosis related pain is not well established, as most of the studies have been in adults. Coming to OC pills and adolescent endometriosis, so there are randomized double controlled trial where 76, this is one particular trial where 76 adolescent girls with moderate to severe dysmenorrhea were randomized between OC pills and placebo, and OC pill users, they recorded a lesser pain score, lower worst pain, and lower analgesic use. So OC pill is quite effective even in adolescent endometriosis. Now, as far as LNG devices are concerned, although they do give benefit, but they are not the first choice. And on use of Dynogest, because Dynogest is very, very popular for adult endometriosis now, and most of us are using it, either GnRH agonist or Dynogest. So what does it say in adolescents? So, there are multiple studies which say that the visual analog score for pain improved a lot. Endometriosis health profile improved a lot. BMD lumbar spine decreased, but again it improved in 1 year, and it is quite effective as similarly as in adults, in adolescent girls also. Now, gonadotropin releasing hormone agonist to be used with a pinch of salt, because BMD is definitely a concern. But yeah, it is also, if nothing else is working, then HRA 2022 says that with for 1 year you can use it with a backup support. So let's, whatever we have seen in the few last slides, let's enumerate it again. So in adolescents with severe dysmenorrhea and or endometriosis associated pain, clinicians should prescribe hormonal contraceptive or progestogens as first-line hormone therapy because they may be effective and safe. However, it is important to note that some progestogens may decrease bone mineral density like GnRH agonist. Guideline development group recommends clinician consider NSAIDs as treatment for endometriosis associated pain in adolescents with suspected endometriosis, especially if the first-line hormone therapy is not an option. In adolescents with laparoscopically confirmed endometriosis and associated pain, in whom hormonal contraceptive or progesterone therapy fails, clinician may consider giving GnRH agonist for up to 1 year as they are effective and safe when combined with add-back therapy. So what we have to remember, if my hormonal contraceptive is not working, progesterones are not working, and I'm jumping onto agonist, then this is a must as in adults also, and we should not be using it too long, and it is not the first preference. Then GDG recommends that in young women and adolescents, if GnRH agonist treatment is considered, it should be used only after careful consideration, discussion of effects, long-term health risk, and it should be done in a tertiary care setting. So, what we conclude about the medical management, GDG recommends prescribing oral contraceptives or progestogens as first line. This is a strong recommendation, and agonist only as a second line treatment if first line treatment is not working. Coming to the surgical treatment, do we, kind of operate all cases of adolescent endometriosis? So definitely not, but if it is symptomatic and not improving with any medical management, then we may have to go on to the surgical treatment. So GDG recommends that if surgical treatment is indicated with endometriosis, it should be performed laparoscopically by experienced surgeon, just like in adult endometriosis, and if possible, the complete laparoscopic removal of all endometriosis present should be performed. So this is the basic principle which we follow. If even in adults they are landing up in surgery, we have to remove all the endometriotic implants and all. So there are not many studies which have talked about the surgical treatment about in endometriosis. So this data is limited, that for benefit of pain should we be jumping onto surgery, and definitely we know that more we operate on endometriosis, the reserves are going to go down. And just now we spoke about the fertility preservation. So even in endometriosis, girls who have adolescent group of girls with endometriosis, we definitely have to talk about and keep in mind this aspect as well. So they should, and if the girl ends up in the surgical treatment, then post-op hormone therapy to suppress the recurrence, it's a must and should always be done. So all the studies, they do recommend post-op hormone therapy. There is a strong recommendation for post-op hormone therapy. So now coming on to, as we said, fertility preservation. So there are mixed opinion, but in the end, even ASHRAE concludes that yes, you should talk about fertility preservation in girls who have endometriosis. So there is lack of robust evidence. This is what they say. But theoretically, it benefits them, but because these girls, they have poor ovarian reserve. And some papers, they say that girls who got operated for bilateral endometrioma and those who were operated unilaterally with contralateral recurrence, fertility preservation may be indicated. So I'm just giving you the opinion of different studies. Cumulative live birth when they had fertility preservation was 46.4%, and it was statistically higher in women who preserved their fertility at less than 35 years of age, and live birth rates were also better when it was done less than 35 years of age. So the guideline development group recommends that adolescents with endometriosis are informed of potential detrimental effect of ovarian endometriosis and surgery on ovarian reserve and future fertility. So here comes the role of counseling, which we all talked about just now, that it is very, very important to educate that lady, that girl at the time when she is coming to me, and the parents who are accompanying the girl, we should at least educate them that this disease is I usually say that endometriosis literally eats up the ovary, and it is even we know that when it starts penetrating and when it starts infiltrating, it is even worse than cancer. So at this point of time, when girls with ovarian endometriosis are coming to us in adolescent age group, this is the time when we should prime the parents, and we should tell them the importance of getting married on time and having kids on time. As Shalini also said, that this should be our the routine education up to the patients. But definitely we have to tell them about fertility preservation as well, and this option does exist, and the guideline group recommends that adolescents are informed about them, although the true benefit, safety and indication in adolescents with endometriosis remains unknown. So with this, I come to the 10 take-home messages from these guidelines. Incidence of adolescent endometriosis is 25 to 73%. History of cyclical, acyclical pain, use of OC pills for dysmenorrhea, nausea with dysmenorrhea, and a frequent history of absenteeism from school, dyspareunia, dysuria, dysgeusia. These all go in favor of endometriosis as far as it comes to an adolescent girl. PV examination is not contraindicated, but you have to properly counsel your patient. And many a times the girl will be sexually active also, because we all are getting, even young girls, and almost 90% of them, they agree that yes, they are sexually active. So PV examination, but you have to counsel the patient before you do PV examination. And if not appropriate, upper rectal examination should be done. TVS whenever appropriate, otherwise transrectal, transperineal scan, and other modalities like MRI. And when imaging is negative, we are not able to find out endometriosis on any of the imaging study, but patient is not responding to my management. This is what I said, that even in those cases, we can offer diagnostic laparoscopy. And whenever we are doing a laparoscopy, we should take biopsy. It will be very good if we can see the histologically proven diagnosis, which may not be there all the time, but we should always try if the girl is landing up um, in a laparoscopy. Then out of all the medical management available, combined hormonal pills or progesterone is the first choice. LNG can be considered in adolescents, NSAIDs can be used. Dynogest is equally effective. GnRH agonist only if rest medical therapy is not effective, not always as first choice. But if nothing else is working for 1 year, you can think of giving this with a proper add-back therapy. Counsel the patient the importance of add-back therapy, BMD, and all those things we should properly counsel. And I will say fertility preservation is a wiser option and better if done before any operative procedure is feasible. So I think that's all for my talk. Thank you so much for the patient hearing. And
Thank you, Dr. Sunita, for your wonderful talk as always. And very clearly, you have highlighted the clinical points right from the diagnosis, the clinical presentation, and the management. And I would request Dr. R.K. Sharma, sir, to please give his expert comments.
Malti, how can I stop sharing? Ah.
We are not seeing here any slide, Dr. Smita.
Uh, Dr. Sunita has really brought in a subject, which as a infertility specialist, we do not come across. The gynecologist would come across this subject much more than what we. But definitely, no, the adolescent endometriosis, plays havoc uh, in all the fields of, the girl's life, whether it's her, educational achievements, her sports achievements, and also diagnosing it early and treating it early is the crux of the whole matter. And not only the IV specialists, I think the grassroots gynecologists should be aware of this. That just prescribing them OC pills and then, okay, you take painkillers and you'll be all right. There's nothing. And when you get married, your pain will go. This is normally a gynecologist would tell the girls. ये होता है इस एज में and pain dysmenorrhea is quite common. So once you get married and you as if the marriage is the treatment. Actually, it is not the marriage; it is the childbearing which is the treatment. Once she becomes pregnant, that would suppress the endometriosis. So that is one aspect. The second aspect is I remember long back when I was initially not a specialist gynecologist. The young girl came and her findings were suggestive of endometriosis clinically as well as her ultrasound and massive, endometrioma on left side. And she was very uncomfortable. And since the endometrium was too big, so it was decided that okay, we'll operate. That time the laparoscopy was not that uh, you know easily available. So open this thing is there. So what I found was she was having one non-communicating horn on the left side. So she had initially hematometra, followed by that she had a hematosalpinx, and from hematosalpinx the blood oozed out into the peritoneal cavity, and then here the whole blood was getting collected over the years. So whenever we have adolescent, endometriosis, we should also try to exclude any, uterine malformations as well, because that could be the reason for, the symptoms and also clinical as well as, ultrasound findings. That yes, it looks like endometrioma, but it was a different story. So, as far as these ladies are concerned, these young girls, it's very pity because such young age they're suffering and the whole life is ahead of them. And, their childbearing, their marriage, all those things are there in front of them. So, the counseling of these young girls and also their parents is very important so that she should not go into sort of depression or anxiety because of her pain and because of the diagnosis and telling her that okay future your childbearing will be affected and and you have to go through operations and all. So here they would require special counseling sessions, the child as well as the parents, so that the anxiety level or the depression should not happen in these patients.
Yes, Shatajan ma'am.
I think this presentation of Dr. Sudita is absolutely great and timely to keep reminding infertility experts that adolescent endometriosis has to be properly looked into it, and the incidence is no less. She has said the incidence can vary from 25 to 75%. And this particular clue that her symptoms, if of pain, if they are associated with nausea, probably should give you a finding that that she probably has endometriosis. And also she also enlightened that in endometriosis, for a diagnosis per se, you don't require laparoscopy, but in case if you find the imaging is absolutely negative in adolescent girls and you need to confirm it, then in that particular case, laparoscopy should be done by a senior surgeon, good surgeon, from the point of view that it can be diagnosed, and histopathology is must in such cases. Otherwise, the treatment, I find since the time the gynecologist has come, it has made life easier for the gynecologist, and now for them also, they can get educated, they can have professional degrees, and they can travel overseas anytime for their career opportunities. Things are great. And I thought I definitely feel that the message must should be there for all gynecologists that somehow the ovarian reserve is lessened in these patients. and every surgery decreases it further. And very rightly, Sunita has said, the endometriosis eats up the ovary, and it's worse than the cancer once it is infiltrative variety. And I have seen, I think those days have gone now almost. You'll find that every month the parents will bring this particular child, really having a lot of discomfort with the pain. That kind of picture is not there now in the last 10 years. So I think the fertility preservation in such patients should definitely be counseled by the gynecologist to them in case if their career oriented. Otherwise, the right advice to the parents is शादी ठीक समय पे करना चाहिए, बच्चे ठीक समय पे करना चाहिए. That's all is there. Okay. So I think thank you again, Dr. Sunita. It had been absolutely wonderful treat to listen to you as far
Thank
as
you, ma'am.
endometriosis was concerned.
Yes. So there's been a question in the chat box. What about the role of free days? Free days, which has both ethinyl estradiol and a combination of Dynogest. What's your experience, Dr. Sunita?
See, similarly, like as sir said, as fertility specialist, I'm also not getting many patients of adolescent endometriosis. But yes, free days, like an oral contraceptive pill, it has got a progesterone and ethinyl estradiol. So it should work as any other oral contraceptive pill. Plus, there is an additional benefit of Dynogest here. So it is a good option to be used for adolescent endometriosis.
Yes, in my experience, like I have used whosoever girls are approaching with the endometriosis, Dynogest certainly really works well. In fact, I have seen decrease in size of the endometrioma, especially if started early, the young adolescent girls. I do prefer giving these either Dynogest, and maybe it at times it becomes difficult to counsel the patient, especially when the girls they come with the mothers they have this fixed error, oh, why my girl is being given the OCP pill, because they think it is only for the contraception. So it is very important to counsel these girls and their mothers also. But in my experience, Dynogest, I have seen shrinkage in the size. So general suggestion that it can be started early, especially in the young adolescents, so as not to decrease the ovarian reserve and to decrease the size of the endometrioma. Comparing Dynogest versus free days, I feel with the free days, I have seen patients complaining of intermenstrual spotting off and on, off and on. So that is why my first preference is Dynogest alone. Or if I have to give the birth control pill, maybe the OCP pill, if a girl is recently married and very young, maybe say 22, 23 years, and she is having endometriosis, then where the contraceptive advice is there, then we can use those pills also, the birth control pills. But yes, Dynogest certainly has revolutionized the world. So the management is very clear, in young adolescents, if the pain is not very severe, the girl comes, the first line we can get that as we can give NSAIDs doesn't work, then we go on to the second line. The choice preference would be Dynogest, or maybe she wants contraceptive, give her then OCPs. And if still not, as Dr. Sunita said, that we can give GnRH analogs and laparoscopy only, not for the diagnosis, for the treatment if she is refractory to the medical treatment.
I
Are
can
there
see
any
a
more
question by Dr. Anchita.
Yeah.
Dr. Shalini, we have time?
Yeah, we can take it up because our session is till 5 p.m. and we have
Yeah.
10 to 15 minutes.
So she has written as fertility specialist in a women with low ovarian reserve with endometriotic cyst of 2 to 3 centimeters. Should we go ahead with OPU even though risk of infection is known to be high? In terms of practical experience, is the egg quality poor in these women? So, 2 to 3 centimeter, I'll say that 2 to 3 centimeter is not a very big size, and it should not stop you from doing your procedure. Rather, uh, surgery is to be taken when it comes to fertility. Surgery is to be taken with a pinch of salt in cases of endometriosis. Every surgery is going to decrease the ovarian reserve. So you should try, unless it is impossible, it's a very big endometrioma, then only it is occupying the whole ovary, then only you should think of surgery first. And we are all doing these cases. I don't think if we are giving proper antibiotic cover, the risk of infection is too high. we should follow those principle of, not trying, not going through the endometriotic cyst. But all of us see that sometimes, when we are doing egg pickup,
Sorry.
not even entered endometrioma, but then from the follicle also sometimes the endometriotic fluid comes up. So you just have to give good cover of antibiotics and should go ahead with the egg pickup. Dr. Sharma sir, what is your opinion?
Yeah. See, as far as infection is concerned, while doing pickup, from where does the infection enter into the endometrioma, that we must understand.
Vagina.
So vagina is one source and the gut is the second source. Because these, endometriomas, they are, fixed and they may be gut around. And we may inadvertently go through the gut and then through the gut to the, endometrioma. So your placement of your probe should be such that, you avoid any tissue between the vaginal wall and the endometrioma. That is the whole important thing. Because if you have taken adequate care, if you have to go through the bladder into the endometrioma, it is all right. But you should never try, if you find some thick tissue between your probe and endometrioma, so most likely it is a gut, don't go through that area. So go only when the endometrioma is just next to your probe, or if it is away from your probe, and if it is near to the bladder, through the bladder you can go it. Like if you have to, take the eggs. But definitely, whenever there's a thick tissue between your probe and endometrioma, that means there is possibility of gut, and from the gut, the infection is likely to enter into the endometrioma. Antibiotics, yes, we have to give to them whenever doing it in doubt. But I think prevention also, these steps should be taken. And these patients, like endometrioma patients, can be given, the vaginal douches much before, during their, preparation for the folliculogenesis. That is the time that, we should make sure that the vagina is not infected. Now, we can do either vaginal cultures or high vaginal swab cultures, or nowadays one stick is available, where you just put it and it shows, infection is there in the vagina or not. And thirdly is that copious cleaning of vagina with copious amount of fluid. Now it should not be, you just dip the gauze piece and in the saline and clean the vagina. That should have done. It should be proper douching with at least half to 1 liter of warm saline, and make sure that your vagina is totally washed. There is no, it's clear fluid which is coming out of the vagina. It should not be hazy or, a milky sort of fluid coming out of the vagina. And after you have cleaned, then the second most important thing is make the vagina as dry as possible. Because if the fluid is there with which we have cleaned the vagina, and as soon as we try to put the probe with the capillary action, the fluid will get into your biopsy guide as well as into the needle, which will carry the infection into your endometrioma. So vagina should be totally dry. One should look at after cleaning, dry it up with the dry swabs, and then again confirm that in the posterior fornix there is no fluid and it is totally dry, and then only you prick the vagina. So then chances of getting infection from the vagina to the endometrioma will also be much reduced. So I have been doing the pickups, the big endometriomas also. I have been doing endometrioma aspirations also during the home pickup, and touch wood, in these many years, not a single case of patient having pelvic abscess or pelvic peritonitis has happened by taking these precautions.
Yes, very rightly said. We all, the necessary precautions are to be taken while doing the pickups, and we should try avoiding puncturing these, because many times, patients and ask, and they come, they ask, they have this query, ki, can this be punctured? So as a good clinical practice, I think we all infertility specialists would agree that we try puncturing these endometriomas. And one point just I would like to add, coming to the ESHRE guidelines and the practical points that we all are doing in our clinical practices. If we are taking, if the patient is for IVF, then even the standard guidelines say that endometrioma should not be removed, because certainly it will reduce your ovarian reserve. But yes, if the patient is young, married for very short time and planning for a natural pregnancy, then maybe you can consider taking her up for a laparoscopy. But even till 4 centimeter of endometrioma, the ESHRE guideline says before IVF, there is no indication that you should remove the endometrioma.
There is a question by Dr. Chandralata that, one of her patient is 26, 27 years old, 12 centimeter endometriotic cyst. You take it from me that if you give a medical treatment, it is not going to respond. This particular patient will require surgery. 12 centimeters is a big size. And then, post-surgical, you have to give a hormonal treatment.
Hormone, ma'am, Dynogest, or we can put on this GnRH?
After surgery. 12 centimeter
After surgery.
After surgery.
After surgery. After surgery. Thank you.
Yes. So I guess we are done with this questions. Any more questions or any more comments from anyone?
Dr. Seema Sehgal is also there logged in. Dr. Seema, you want to add something?
Can I come in?
Yes, ma'am.
Ma'am, whatever these adolescent girls, because I am not an infertility expert, but the adolescent girls are coming for their treatment, and I think 50% of them are having this endometrioma. And with the clinical depth, if you go in detail with the history, you can make out that these are the suspected case of endometriosis confirmed by the ultrasound. And most of the time I am giving this, and most of these girls are sexually active. So in these girls, I find giving the free days non-stop, which act as a contraceptive also, is a better option rather than putting them only on the Dynogest. Because on the Dynogest, I've seen 1 or 2 patient has conceived also. That's the one thing. Second, I have used the Dynogest for a year, giving a gap of 1 or 2 months, and then again up to 3 years I have an experience, and the results are very good. The patient becomes symptom free, and once they get married,
Yes.
we usually advise the counseling ki yes, get married, don't delay your fertility. Your AMH is going to go down with the further progress of the disease. The second thing I'd like to know, do you get the AMH before and after the surgery always, or it is not done at all?
No, ma'am.
Always.
Always we get it done before the surgery and after the surgery, but not right immediately after the surgery, because it takes 2 to 3 months for the ovarian reserve to come back after an endometriotic surgery.
So what is your study whether the AMH is supposed to improve after the surgery? That is what I read somewhere.
No, certainly not, ma'am, because once you're doing a surgery, however the good surgeon may be, while doing an endometriotic surgery, while you're doing a cystectomy, the ovarian reserve does go down. And especially obviously we do not do fulguration, we do cystectomy only. So it is a known cause of decreased in the ovarian reserve after an endometriotic surgery, ma'am.
Ma'am, counseling should always be that
Yes.
AMH we always do before surgery, and the counseling has to be that after surgery there are more chances that it will go down only and will not remain the same. And we always counsel the patient that immediately after surgery, definitely there is going to be a sharp decline, and then 2 to 3 months later it may slightly come back, but it may not come back to your original. That counseling has to be there in all the cases of endometriosis. It's a must.
Yeah, and in fact, at times the management has to be individualized, because suppose a patient is keen for pregnancy also, and she has very severe pain. Then at times we do ovarian reserve and freezing the embryos also. Like first we do the IVF, freeze the embryos, then take her up for surgery. With this logic only, that any surgery would certainly lead to fall in the AMH levels, and then do a embryo transfer after that.
Usually we counsel the patient that this endometriotic surgery has to be done once in a lifetime. So it's better to get married if you plan to have a child, because most of the girls, they don't plan to, even if they get married, they don't want to have the child.
Yes.
So all these counseling are very important in adolescent, right from adolescent age.
I guess some doctor had raised the hand. Yes, Anchita.
Hello, ma'am. This is Anchita here. Regarding my previous question only, I had just one small doubt. A few of my friends and colleagues, they are using this for the same kind of patient, actually, they usually go for something like a 3 to 6 month oral therapy with the OC pills or Dynogest, and then go for OPU. I mean, you guys are very experienced. You would know. Does it yield any results, or is it better to go for OPU in the cycle when she comes to us?
So once you have decided that your patient is for IVF, then this medical management is not going to improve your success rates or your quality or anything. But one thing is there, as Dr. Chandralata also put a question, 12 centimeter severe pain. So this kind of a presentation of severe pain, sometimes maybe they are in a smaller endometrioma also. The girl is in such a severe pain, it is only a 2.53 centimeter because maybe it is infiltrating one. So there, with severe pain, those patients are not going to allow you for egg pickup. Their first priority, obviously your first priority is also to make them pain free. Now, in those cases, that is the only condition where if you don't want to touch your patient surgically, can try medical management, because there are patients who are coming to OPD and they are in severe pain referred to you, and you have to make them little comfortable before taking up them for surgeries. I think that is the only class where you can think of doing this. Otherwise, literature strongly says against this, that medical management in pre-IVF time is not going to improve any results in any manner. So that's not recommended.
So basically, this 2 to 3 centimeter cyst, whatever is there, it won't reduce in size, or it won't have any effect on that.
It can reduce in size with medical management, but it is not going, you don't want to waste 3 months in giving medical management and losing time on doing your fertility treatment. That's why.
Yeah.
Thank you,
Yeah.
ma'am.
In fact, the results have shown that there are two protocols. Earlier, it used to be that the long protocol works well, but now the antagonist protocol works really well in cases of endometriosis. Earlier, we were giving the long protocol or the GnRH analog protocol because it would cause the suppression of the endometrioma. But on the reverse, if the ovarian reserve is less and she has endometrioma, that would further lead to the poor outcome. So the antagonist protocol works fairly good in these patients.
After the egg freezing, after the embryo freezing, I think they should be given, antag to be given consecutively after that and not before that.
Yes, ma'am. Yeah, we can give GnRH analogs once the embryo freezing is done. So,
Wind up, doctor, wind up.
yes,
Wonderful.
with this, we wind up this session, and I request Dr. Sunita Arora to give vote of thanks.
So thank you everyone who joined in, and me, I with Dr. Shalini, I would like to thank Dr. Sharda Jain ma'am. She has given us this responsibility of holding this meeting every 20th of every month. And ma'am has really set standards so high, and hopefully we will be trying our level best to give you good academics. And we seek more and more people to join in. So we'll be giving a lot of variety. We'll discuss it out with ma'am that how further we can work on this. So we all see you on 20th next month. Thank you so much, Dr. Sharda Jain ma'am, for having
You are the boss. I am told that you are Delhi chapter of Ishtar is going to have you as a president. So I think this forum is for you for 1 year. The only thing is that Brigadier Sharma has to be there in loop, because he's the chairman as far as IVF and infertility committee is concerned. So
Right,
thank you very much.
Sure.
Thank you very much.
Thank you, ma'am. Thank you so much.
ma'am.
Thank you, everyone.
And
Thank you.
thanks to all the delegates for joining. Thank you. Thank you, Sharda ma'am. Thank you, Brigadier sir.
Thank you.
Thank you, sir. We take your permission to leave, ma'am.